This week in infectious disease, we're seeing two very different threats. One, we know how to stop, and that's measles, continuing to impact the United States. The other, avian influenza, we don't quite know how to stop. We've got important tools, but it continues to spread, continues to raise questions about its ability to cause a pandemic. And that question is not if it can cause a pandemic, but when it might cause a pandemic. So I'm going to walk through measles, avian influenza, and other data to see where infectious disease is heading this week. So I think the first thing is to continue to talk about measles, as I have been for weeks and weeks. This has basically reestablished endemic status in the United States, and we continue to see multiple outbreaks in multiple different parts of the country. So, for example, in Florida, we have a high school that might be impacted by measles. We have Arizona reporting the highest levels of measles in Maricopa County in 30 years related to a basketball game. We have measles clusters at the Utah border in Arizona as well. Pennsylvania has had measles cases, particularly in Lancaster County, where vaccination rates are very low in certain schools, and also Maryland reporting their first case. It's going to shift every week. Different states are going to be impacted because this is what it means to not be able to control measles. This is what it means to have vaccination rates below herd immunity thresholds. At the same time, global outbreaks are occurring in places like Bangladesh and the DRC, where the issue isn't that people don't want the vaccines. It's that they can't get the vaccines because of political turmoil, because of disruptions. So the very opposite thing happening in places in the world in which measles is also endemic and has been endemic and never been eliminated. Coming back to our school vaccination rates. In many schools, what you see are low numbers of individuals vaccinated. Even if it looks like on paper a school might be okay, in real terms, if superintendents, school administrators are issuing provisional admission saying they're going to get the vaccine at some point, what ends up happening is vaccination rates dip very low. In some school districts in Pittsburgh, for example, 70s and 80%. That's way too low for measles. All it takes is one infected individual to show up in a school like that, and then you have widespread measles because the virus is going to find the unvaccinated individuals. Even in adult populations, there was a study in emergency department showing 50% of adults aren't up to date with measles, and 1 in 4 don't even know what the MMR vaccine is. That's a weird study. I don't know how 1 in 4 adults in the United States don't know what MMR is, but it was reported in a study. But I think it's a sign of the times that we're in this situation where vaccines are undervalued. People don't understand them as pieces of technology that help us navigate a world, and this is the result. Remember, measles is the most contagious human infectious disease. So when you see measles cases rising, you have to think of them as a barometer that our whole system of controlling infectious disease is in trouble. This is a sign of system failure. It means that vaccine infrastructure has broken down. And remember, this is a fully preventable disease, and it's resurging not because of something it did, but because of something we did, based on human decisions, human choices. Other things, so when you speak about this vaccine system breakdown, it's not something that's subtle. It's very obvious in the United States because of who is in charge of the Department of Health and Human Services, and that's RFK Jr. What you have seen is massive disruption of the entire ecosystem around vaccines. For example, the Advisory Committee on Immunization Practices. Now a judge has stopped that from operating because of the way that RFK Jr. has hijacked that. And what's going to happen now is it's going to put us in a policy constraint because many insurance companies' decisions to cover or not cover vaccines are based on ACIP recommendations. The ACIP is now unable to meet because RFK Jr. basically destroyed it, and a judge said this whole thing needs to be figured out again. So we'll see what that means for insurance company coverage for vaccines. They've committed to covering them for some period of time based on prior recommendations from the ACIP. And certainly there is a business case for them to cover these recommended vaccines. And likely what will happen is they'll look to professional organizations like the American Academy of Pediatrics to help them make those decisions on which vaccines they should cover. Another aspect of the way the government has been handling vaccines is the military. So the military is highly susceptible to influenza. 1918 may have originated on a military training camp. And 1918's spread was facilitated by soldiers moving all around the world, as well as training camps with increased population density. Influenza, is something that can really disable military readiness, decrease their resilience. But yet in the United States now, you have the Secretary of Defense saying, we don't need an influenza requirement. We don't need to be resilient against 1918 because we're tough, or influenza because we're tough guys and flu is an old person's disease. That's not true. And what this does is decrease force readiness, puts us at a disadvantage, and unnecessarily increases risk, increases the chance of harm for no benefit at all. Studies are also showing now that 25% of Americans believe that vaccines are a form of population control. That sounds absurd, but it is one of the talking points of members of the anti-vaccine movement, when the exact opposite is true. Higher vaccination rates increases populations because it decreases childhood mortality. Another aspect of this, nursing home patients, some of the most highly susceptible to infectious diseases, especially influenza. Not only are they susceptible to having severe disease, they're susceptible to having major outbreaks in nursing homes. An elderly person is less likely to be vaccinated if they're in a nursing home under medical supervision than they are if they're out in the world, not in a nursing home. That's paradoxical, and it really speaks to what happens in nursing homes. The point is that policy decisions affect vaccination rates. Public trust continues to decline, and the most vulnerable populations are not getting protected, which is what the whole goal of vaccination policy is. It's to prevent severe disease, hospitalizations, and deaths. And this misinformation or disinformation is probably more accurate, is really translating into real-world disease. This isn't just a medical issue. It's a massive breakdown in public health infrastructure and trust, and we will pay for it. Shifting now to avian influenza. As I've said multiple times, I think that avian influenza viruses are the biggest pandemic threats. They will cause pandemics just like they did in 1918. What we know is that H5N1 continues to spread. It's spreading in poultry, in ducks. It's spreading in marine mammals in places like San Mateo County in California. It is spreading in bald eagles in places like Pennsylvania, my home state. But we don't know what's going on the human side. Are humans getting tested? What is the rate of their infection? This is something that we really have to be proactive about, or we're going to face major issues with a pandemic threat that we are ill prepared for. Dairy cattle getting infected, dairy cattle in Idaho, a new farm infected. How many of those farm workers were tested? What's the denominator? What's the numerator? We don't know. So we're flying blind with H5N1. At the same time, another strain, H9N2, is increased its activity in China. It's been increasing its activity in Cambodia, but increased in China year over year. And I think it's one that we have to keep an eye on as well, because it's not just one strain of avian influenza. There's a swarm of them that have been changing their behavior or infecting more humans. And that's another one. Cambodia and China. There was a case in Italy related to a traveler from Senegal. This is another one that I think needs to be appreciated more. Vaccines are going to be the way out of any influenza pandemic. But yet in the United States, HHS canceled the mRNA vaccine contract with Moderna for H5N1 vaccines. On the other hand, the United Kingdom has welcomed it. So you're seeing vaccine research against H5N1 move to England. This is a good thing that countries are being proactive, that Moderna is continuing this research. But in the event of a pandemic, you can expect the United Kingdom to be protectionist, to issue export restrictions, and not allow that vaccine to leave England or leave the UK until its population is vaccinated. So what you're seeing is less resiliency in the United States, and that resiliency moving to other focal points in the world because of the anti-vaccine sentiment, the anti-mRNA vaccine sentiment of the Secretary of Health and Human Services. These increasing opportunities for human adaptation that are occurring kind of under the radar of our policymakers is concerning. And more each week, early warning signals are accumulating. And remember, this is one that is an unknown threat. We don't know exactly how it's going to emerge. We don't know which strain. So we have to be proactive and not ignore these warning signals. I want to turn now to COVID in 2026. I think we're entering a new phase, and some studies came out this week regarding Paxlovid. And Paxlovid was an antiviral that was a breakthrough in unvaccinated populations. Basically, no one died who took Paxlovid, and the ability to prevent hospitalizations and serious disease was above 90% range. The question arose, does Paxlovid still pack that same punch when you have a population that is highly immune from vaccines, highly immune from infections, highly immune from combinations of those? The answer seems to be not so much anymore. The Paxlovid, even in those high-risk patients, is not able to prevent hospitalizations or deaths at the same rate because there's so much immunity, so it's a much harder hill for it to climb. It doesn't mean it's completely ineffective. It clearly decreases viral load, which would then decrease contagiousness, and it clearly gets people better faster now. So maybe the purpose of Paxlovid has changed a little now that we have a population that's changed because their immune systems are now much more experienced with COVID-19. And I think that speaks to the need for newer antivirals that do other things like prevent long COVID or could be used as post-exposure prophylaxis. So I think what we're seeing is kind of a transition as COVID becomes more of an endemic disease. Some of those tools have different uses now. And I think the treatment goals are shifting more about prevention of long COVID, getting you back on your feet faster, making it less likely that you have to call off work. That's what we're trying to see, but that's what we're kind of transitioning towards. But make no mistake, COVID hasn't disappeared. It's still killing people. It's still hospitalizing people, but but the whole context of COVID has changed. The other point of what I'm trying to say this week is that, and I think it's not just with COVID, not just with influenza, not just with measles, it's with infectious disease in general. This isn't a technological problem anymore. We have a lot of tools. We're just not using them. So let's think about other infectious diseases where this theme applies. Hepatitis C. We have a cure for hepatitis C, but prescription rates are going down. The number of new cases of hepatitis C are basically equaling the number of cured cases of hepatitis C. So we're clearly not testing enough. We're clearly not treating enough hepatitis C, even though this is a threat that can be taken off the table right now. Malaria. Deaths around 600,000 this year. That's higher than last year, but this year we have more tools for malaria. We have 2 vaccines that are available for use in malaria, which tells us we're not using them impactfully if deaths are going up, even in the face of vaccines. HPV, human papillomavirus. We have a cancer-preventing vaccine that is being underutilized. We have home tests or home collection tests for HPV as well. So HPV is something that should be on its way out in the United States. It's on its way out in other countries like Australia, for example, but it's still not utilized enough in the United States. Mpox. We continue to find Mpox cases in unvaccinated individuals. There was a major push to get people vaccinated, but that high-risk population of men who have sex with men, not all of them got vaccinated. It's a 2-dose regimen, and there are many people that are still susceptible that are out there, and we still see Mpox cases occur, including Clade 1, the more severe strain in the United States. So what that means is these are implementation failures. They're not scientific failures. The science actually delivered. It's the implementation that's failing. And outcomes are being driven not by the technology, but by behavior. And I think that's harder to fix. And I think that if you think overarchingly, modern infectious disease is increasingly about whether we use our tools, not whether we have them. And I think that's also a theme of COVID. We have the greatest toolkit against COVID. We had that toolkit against pandemics prior to 2020, yet it was not used appropriately. Misinformation is a major health threat, and I think we're seeing that as well integrate with the fact that we're failing to use our technology. And I use the word misinformation, but really, in many cases, it's disinformation. It's deliberate. 25% of the population, I said, has vaccine conspiracy beliefs. They believe it's a tool for population control. They say the same thing. They think raw milk, 25% think raw milk is better than pasteurized milk, as if Louis Pasteur just decided to pasteurize milk or make the pasteurization process just for fun, like as if it wasn't something that was trying to solve a human problem. Anti-vaccine narratives are increasingly shaping people's behavior. But there is one, sidelight to this that I think is important. There is an online community called Back to the Vax for individuals who are sort of being deprogrammed or have decided that the anti-vaccine movement was lying to them, as it does, and they're trying to remove all that disinformation from their mind. So that's reassuring, that's encouraging that there are these Back to the Vax communities that are out there. But in general, it's really important to know that beliefs and ideas directly influence infectious disease spread because of the actions people take. People are motivated by their beliefs, motivated by their ideas. And what you have is science and public health and medicine competing with complete disinformation ecosystems. And that's not a good situation. Disinformation is not some peripheral thing. It's actually driving infectious disease outbreaks now. And I think this is what is probably going to be the theme next week as well. The same things keep coming back because we're not dealing with the root cause, which is the ideas that are motivating people to not take the appropriate protective actions, to shun technologies, to deny the benefits of vaccines, and really to allow this anti-human viewpoint, and it's an anti-human viewpoint, to dominate their thinking and then influence their behavior, and in turn allow infectious diseases to continue to impinge on civilization.